or Cleveland, Ohio, and a breast oncologist at the University of Stedman Cancer Center, Cleveland, Ohio, for the past 17 years. Now, also a Wesley Girls for alumni from 1982 year group, a complete School of Medicine in 1991 at KNUST of Medical Sciences, Ghana in hematology, oncology, training at Boston University Medical Center, Boston. In addition to her clinical practice in breast cancer, Dr. Owusu is an NIH-funded researcher whose work focuses on health outcomes and health disparities in breast cancer patients. And in addition, Dr. Owusu is the Director of Diversity, Equity, and Inclusion of the CASE, Comprehensive Cancer Center, Cleveland, Ohio. Dr. Owusu is married to a medical oncologist, has 2 sons, and enjoys community outreach activities that cater to the needs of the undeserved. And this is Dr. Owusu, Cynthia Owusu, a little bit about her and I'm making trauma. Now, me did say you may rather be funny so a boy, ama near me be a yen muntia science or so. What funny so I'm a yen muntia see. Now, me who Auntie Dinah Frimpong was so. Your man shout out so about the support again, once again, this month of cancer. As one Dr. Cynthia Bebano, Sister Irabna, Ebema ye strong. Now, we are near better Dr. Cynthia also. Damas.
Mpacha Befa your theme song no free hymn number 636. God is giving us no waiting from your rich and endless store. Nature's wonder, Jesus' wisdom, cosmic force, grace shattered door. Entered for wait to you. That whose song shall rise forever, gracious dawn for days. Skills and time are lost for blessing, tells the course of Christ's Son. All at peace in health and freedom, bless His strength, the church made one. Know the Lord of the favor, lest we strive for one with talent, make us servant, peace to oneself at your throne. Treasure to you have entrusted, may the your grace confirm, us to use for hope and kindred, and to spread the gospel word. As we teaching and reclaiming, serving you by loving all.
Good evening, church. Pepacho, motimekasa. Good evening to everybody.
Good evening.
And thank you so much for Women's Ministries leadership for this invitation. So, member mamu information about breast cancer, given that this month, Breast Cancer Awareness Month. But of course, the first glory and the first thanks goes to God. Now, I have a couple of questions. Do you want me to present in Twi, Anna in English, Anna in both?
Yeah,
English, please, English.
English. Okay, no problem. The second question is, how long do I have for the presentation? Because that will guide me as to how much information I should be delving into. How much do I have for the presentation? How much do we have for questions and answers?
45 to 50 and then 20 for Q&A.
Wonderful, thank you. So I'm going to share my screen now. So if you can, oh, it says sharing is not turned on. Send a request. So I'm sending a request. If you can kindly turn that on for me, I'd appreciate it. Okay.
Sorry, Dr. Cynthia, if you could mix the languages, that's preferred, but nkrofo so munti Twi na kra.
Okay, that's okay. Okay. Are you able to see my screen? Pepacho, muhu screen. Are you able to see the screen?
Yes.
Okay,
Yes.
very good. Excellent. Okay. And so I've entitled this presentation, Empowering Women Through Breast Cancer Awareness, because knowledge is power. If you have knowledge and you are aware of what breast cancer is and how you can prevent then you can avoid it. The mention is a breast cancer church ni important. So and I'll bet me abo ban if we say into the presentation outline. This is how it's going to go. I'm going to talk about facts and figures in breast cancer in the US and also in Ghana. Ghana, because most of us have, almost everybody is from Ghana, essentially. And even though we live here, we have relatives in Ghana. So some of this information you can share with your relatives in Ghana. I'll then go on and talk about what breast cancer is, and then I'll zoom in on the screening and early detection, because that's very important. That's what breast cancer awareness is about, screening and early detection. I'll also talk about breast cancer and the African American woman and what that means for us. If there is time, I'll talk about breast cancer treatment. Important as that is, that's not the focus of breast cancer awareness. So if we don't have enough time, I'll skip that. It's about 9 slides over there. I'll skip all of that and I'll go to risk factors and prevention. Okay, see, let's go. So breast cancer facts and figures in the US and in Ghana. So what is the size of the problem in the US? In the United States, breast cancer, how many women and amphibia breast cancer? Okay, so breast cancer is the leading cause of female cancers in the US. United States, yefa emane cancer breast cancer in a decline. Over 300,000 women will get breast cancer this year, 2024. Unfortunately, it's the second leading cause of breast cancer death in women, second to lung cancer. Okay, breast cancer is the leading cause of cancer in females and is responsible or is the second leading cause of death. And unfortunately, 42,000 women about will die from breast cancer this year. That represents about 15%. What does that translate to? When we have mammo numbers, when the numbers are that big, it becomes difficult for you to translate. But when we translate it to every day, then it hits home. That translates, those numbers I gave you, every day, 850 new cases or women will be diagnosed with breast cancer in the United States. Every day, 850 women. And unfortunately, 120 women every day will die from breast cancer, unfortunately. In a woman's lifetime, if ɔbaa yɛnya wo kɔpem sɛ wobɛwu no, yɛfa enipa ɛmaa 8 a emu baako ebenya breast cancer. 1 in 8. That is every woman's risk in their lifetime. 1 in 8. That's how common breast cancer is. So essentially, this is trying to say breast cancer is a disease of women. It is common. A lot of people hide it. Nipa disienti no ya na ufa nipa nwɔtwe a emu baako biya benya breast cancer. Okay. So information I'm all of that information is quite depressing, but wait, there is hope. Hope. And this is the hope. When breast cancer is caught in its earliest localized stages, the 5-year survival rate is over 99%. Essentially, if breast cancer is caught early, you will not die from it. The only way you die from breast cancer is if it's caught when it's stage 4, meaning it's spread over your body. That's when you die from it. If you're doing your mammograms, you're very conscious of it, and it's caught early, there's no reason why that should happen to you. So that is the hope. And there's evidence that it is working. Okay. So when I talk about there is evidence, this information was just released by the American Cancer Society on the 1st of October to coincide with the Breast Cancer Awareness Month or initiative. Since 1989 to date, breast cancer death rate has dropped by 44%. And essentially, over 500,000 women who otherwise would have died from breast cancer are alive today. So that is the hope. And I'm going to tell you the reason why this is happening. And in this corner here, I have a graph to depict that. Hope I want to say, breast cancer, first, no, nanka nipa bebre ewo no, nansen no, omahu say, nipa bebre survive breast cancer. See, that's what this is showing. So this graph here, the light pink here depicts the death rate for white women. And the deep pink here is the death rate for African American women. The rest are for the other races. The important thing I want you to see is, yes, breast cancer death rate back in the 80s was increasing. Then in the 90s, it began to decline, both for white women and for African American women. There's a gap here, and I'll talk about the gap later, but suffice it to say that the death rate is declining. And what is the reason for that? The reason for that is early detection. Mammogram. early detection, and also recent advancements in treatment. So when you go to your doctor and you've been diagnosed with breast cancer and they tell you this is the treatment you need, listen to your doctor. Muntie mo doctors, because so when undergo treatment now, you will not benefit as other women are benefited. Afraid Ghana, what is the size of the problem in Ghana? Breast cancer is the #1 cause of female cancers in Ghana. This data is coming from GlobalCan, WHO essentially, and it's been updated up to 2022. So this is not old data, this is fresh data. Breast cancer is responsible for 31% of all newly diagnosed female cancers in Ghana, okay? Now, death rate from breast cancer. So in Ghana, breast cancer is the #1. Remember, in the US it's #2, but in Ghana, it's the #1 cause of death. The other thing I want you to note here is that over 2,000 women died from breast cancer. If we go back to the previous slide, about 5,000 women were diagnosed with breast cancer in Ghana. If you do the math, half of the women who are diagnosed with breast cancer in Ghana unfortunately died from the disease. This is in contrast to the United States, where they have advanced treatment options, where approximately 15% die. And so there is much work to be done in Ghana to try and ensure that women also benefit from treatment, as is happening in the US. Okay, so now we are moving on to what is breast cancer. Breast cancer, no, and only DNA. Okay, and you know, I have a picture here. This is what we call a cross-sectional area of a woman's breast. Fanisa Obani, now you may fancy the second pie, nenufu numudia na yehu. So this here is the rib cage. So the breast is resting on that rib cage and there's muscle around it. So now we come to the breast itself. The breast is practically full of fat. So this is all fat. The more fat you have, the more sag, how do you say it? That's when people's breasts sag. Okay, younger breast has less fat. That's why it's upright and dense. Okay, so this is all fat. Now, within the fat, we have what we call lobules. This is the factory that makes milk. And then this milk is then transported through ducts to the nipple. So this is the anatomy of the breast. Cancer can start growing in these lobules or in the duct. So when you have a cancer diagnosis, they will tell you you either have lobular carcinoma or ductal carcinoma. It doesn't make much of a difference in terms of the behavior of the cancer, but suffice it to say, it gives an idea. When the pathologist says it's lobular carcinoma, we know it's coming from the lobules. When they say it's ductal carcinoma, we know it's coming from the ducts. Okay, so these are the two types. And cancer is essentially part of your body for a variety of reasons, a lot of it even unknown, where that part of your body begins to grow out of control. And it doesn't want to stop. Normally, your body stops the growth as new cells are being formed. You know? Then the body is killing the cells off so that it maintains a normal structure. When cancer happens, that there's an imbalance and there's growth. So in breast cancer, you're going to see the cells in the lobules grow out of control, or in the ducts grow out of control. And I have a picture to explain just that. So the duct duct on the IS a pipe, no baby a milk nefa a nipple, no. If you cut across it, this is what you will see. So this is a normal breast duct. This is the wall of the duct. You see how the cells are all neatly packed or neatly arranged. Okay. When you have breast cancer, you have one of these two situations arising where the cells begin to multiply, but they all stay within the interior or the lumen of the duct. You can see that the wall is intact, nothing is going out. This is still breast cancer, but it has a special name. It's called ductal carcinoma in situ, DCIS. It is OB atibibisa. That's what it is. We also call it non-invasive because it doesn't invade through the wall. It still needs to be removed, but that's what it is. Invasive breast cancer, which is typically what we hear about a lot of times, is when these cells have the ability to break through the wall and try and get to the bloodstream to get to multiple organs in your body. That is what we call invasive breast cancer, and that is what we commonly see. Okay. There's also something else we call grade, which tends to confuse people because some people confuse grade with stage, and I'll talk about stage shortly. So when we talk about grade, we are referring to how angry the cancer cells are, because if they are angry, if they are aggressive, they can spread quickly. So grade 1 is when the cells are very neatly packed, uniform size. They look like normal breast tissue. And this is what the pathologist will see. And yet, you as me as a physician, I can't even see that. It's the pathologist who tells us whether this is an aggressive cancer. This is an aggressive cancer. The highest grade we have is grade 3. Osha, the cells are all abnormally shaped. They are growing on top of each other. So somebody can have a stage 1, meaning there's a small breast cancer, but it is grade 3. It's aggressive. It has the potential to spread very quickly. When we see things like that, we don't waste time, because that's a kind of breast cancer that's going to grow very fast, as opposed to when it's grade 1, we know that it's not a fast-growing breast cancer. So that is what grade refers to. Okay, so now we're going to talk about stage. So we talked about grade. Now we're talking about stage. So there is stage 0, which is DCIS, the non-invasive breast cancer. Now I can't just a while ago. And the 5-year survival rate is 100%. Nobody dies from DCIS. When the doctor tells you have breast cancer, and the doctor tells you it's DCIS, because they said breast cancer, you don't even hear the DCIS. And a lot of women panic and have a lot of anxiety. It has to be removed. You have to take a pill. But frankly speaking, it's non-invasive. We remove it because it becomes a risk factor for you to develop a new breast cancer. And that new breast cancer could be invasive. So as soon as we see it, we remove it. But by itself, it's stage 0. Okay. Stage 1 means that your breast cancer is small. It's just in the breast. It hasn't gone anywhere. 5-year survival rate, almost 100% as well, 99%. Stage 2, the breast cancer is a little big. It's gone to your armpit. It's traveled to your armpit, and we check that all the time to see what's going on in the armpit. Even then, if you take 100 people with stage 2 breast cancer, follow them forward in time for 5 years, 93% or 93 out of 100 would be alive and free of cancer, cured. So that's what we mean by 5-year survival rate. Stage 3, it's a big cancer. It's gone to your armpit. It's even gone to lymph nodes in the middle of your breast. Even that, the survival rate is 87%. And so advancement in treatments have made these rates look the way they are. Rates when they used to be very bad. Stage 4 is when the cancer has spread. It's gone to perhaps your brain, it's gone to perhaps your liver. That is when, unfortunately, you succumb to the disease. So all attempts are currently focused on making sure that, one, you don't get breast cancer. Even if you get breast cancer, maybe stage 1 or stage 2 or stage 0, because if it is, we can cure you and you are going to be alive. And that is the hope. Okay. I talked briefly about ductal carcinoma. I didn't give any statistics. About 56,000 a year, or in 2024, 56,000 women are going to be diagnosed with DCIS. Remember, the invasive one, I said over 300,000. So it's a smaller number of women. Okay, and I did mention that DCIS was stage 0 with 100% survival rate. Okay, so now we're going to move on to screening and diagnosis of breast cancer. And this information is critically important. Afei deɛ ɛbɛka mammogram ho asɛm ne ade, mepɛ sɛ motie ne yie paa, because ɛno na ɛbɛboa sɛ one no, sɛ wonya breast cancer koraa yɛbɛhu no early na amfa ɛyi biara mmrɛ problem biara mmrɛ. Okay, so mammogram, what is it? A mammogram is simply an X-ray. A lot of people get worried, I'm getting too much radiation if I have to do it every year after every year. The amount of radiation you get is nothing, really. And what a mammogram does is that it helps to detect breast cancer early. And I think, say, I've established why your breast cancer needs to be detected early when it's stage 0 or stage 1, okay? So mammograms have the ability to find breast cancer even before you can feel or see anything. And that is the beauty of a mammogram. That's why mammograms translate to saving lives. If they can detect it even before you can feel anything, then it's essentially a stage 0 at that point, okay? There's a lot of confusion as to, oh, how about ultrasound, how about MRI? Mammogram is currently considered the gold standard for breast screening. Test the BNU why I omitimi prove say etimi save lives. Just a mammogram, and therefore mammogram is the only test for screening. Who said there's anything abnormal, we do additional tests, but for screening purposes is the mammogram. And it is the only test shown to reduce death from breast cancer, and it decreases breast cancer related deaths by 30 to 40%. So that's the background to mammogram. Until currently, what are the recommendations? These recommendations that I'm going to give you is from the American Cancer Society. Some of the other organizations have slightly different recommendations, and I'm not too sure about Canada. And I apologize, I should have looked at the Canadian recommendations. Anyway, any woman in the US, American Cancer Society recommends that any woman between the ages of 40 and 44 can have the option to start screening with a mammogram every year. However, once you are 45 to 54 years, you should get a mammogram every year. If at that point your mammograms have been normal, it is okay for your primary care physician to switch you to every other year for you to have your mammogram. Your mammogram should continue for as long as you are in good health. And if your life expectancy is considered to be at least 10 years, then it is worth it. An 85-year-old woman, she doesn't have any medical problems, any medical illness, could go and have a mammogram. 75 could go and have a mammogram. However, if you have a lot of medical illnesses, those rather might actually affect your health, then going to do a mammogram does not make sense. You need to worry about your heart disease and the diabetes and the kidney failure and things like that. So that's what they are trying to say. Okay, so what should you expect during a mammogram? Okay, a mammogram now. What is going to happen? And I have two pictures here. Let me talk about this first, and I'll come to the picture. It talks about one, when you go and do a mammogram, your breast is going to get compressed. That's how they're able to see through your breast and see whether there's a mass in there. Unfortunately, those of you who've done mammograms, the compression can be a little uncomfortable, a little painful, but it's necessary, and it's only for just a few seconds. So your breast is going to be compressed horizontally, and then they will compress it diagonally. Okay, so these are the pictures that I show here. So this is a horizontal compression, and then this is the diagonal compression. And you have to hold your breath for during that period that they are taking the pictures. So that's how a mammogram is done, and that's how it looks like. There's also something called 2D mammogram versus 3D mammogram, and a lot of patients tend to have questions about it, so I thought I'll briefly talk about it. In the past, all we had was the 2D, but now we have tomosynthesis, which is the 3D. So as the picture is showing here, that in the 2D, the picture is taken, it's one image, which is taken from the top, and then they take a second one from the side, so it's static. The 3D actually takes multiple pictures in an arc. So it's multiple pictures. And the pictures really look more like three-dimensional as opposed to a flat plane picture. So needless to say, the 3D is a better approach to getting your mammogram. These days, I think all insurance, at least in the US, all insurance companies cover for the 3D to be done. I'm not too sure about Canada though, but even if the 2D is being offered, screening, mammogram screening is mammogram screening, and that is better than not showing up for your mammogram. Okay, so what do radiologists look for when they do the screening mammogram? So I'm showing a few pictures here. Here, all these white things, they look like crystal salts, right? These are called calcifications. And mostly, this is how ductal carcinoma in situ, the cancer that I said is in the lumen of the duct and doesn't have the ability to get out of the duct. Normally, this is how it looks like. Occasionally, there can be an invasive component hiding within this, but for the most part. So when the radiologist sees this, they know they need to do a biopsy. On the right here, I show four pictures. This is how a mass looks like on the mammogram. This is breast, as you can tell. There's a mass here, okay? Now, here we have a mass, but we have a little background speckles. These could be calcifications as well. And then increasingly, the mass is now buried in the middle of a lot of white stuff. And guess what that is? That is what we call dense breast. And you can see that by the time we get to this extremely dense breast, you can't even see the mass. There's a mass hidden in there. So that's the danger of having dense breast. Dense breast, it does two things. It can hide a mass. By itself, having dense breast places you at future risk of developing breast cancer. It's a risk factor for breast cancer. So it has two effects. And like I explained before, dense breast results from having less fat in your breast. and having other tissue in your breast, fibrous tissue. Until younger people tend to have dense breasts, younger women. Older women, not so much, because as you get older, you build up more fat in your breast and lose tissue in your breast. So typically, that is what you see with dense breast. These days, in the past, when we saw somebody have dense breast, then we would do an ultrasound as a follow-up. These days, with the best test, if somebody has dense breast, is an MRI of the breast. Okay. If they find a breast, then they need to biopsy it. Radiologist is the person who biopsies these abnormalities on the mammogram. And there are typically two types of biopsies we will do, what we call ultrasound guided. So this is the mass here. They're going to use an ultrasound to locate the mass and then go in with a needle and then biopsy it. Is done right there in the breast or mammogram suite. They just give you local anesthesia. If it's done well, it's painless. Okay. If they see those calcium deposits or crystal salts, you can't do an ultrasound, cannot pick it up. So they do what they call stereotactic biopsy, and that is how that is done. That is also all outpatient. They've numbed the breast so the person is not feeling any pain. Okay, once these biopsies are done, it is sent off to the pathologist. Okay, so to explain in Twi, so we mammogram no say duana bibi shakwa. Now was a omuko, no take a little sample of mass, no to collab, no she at the crow. Intinu say na omuyano, omuyano mammogram suite wa nyadia eya. Inti sa doctor na kase was a biopsy, and my William and show and your operation, a very minor procedure. Okay. When we do a mammogram, what is the likelihood that it's going to come out normal? A lot of people or a lot of women don't want to do a mammogram because they don't want bad news. I'm here to tell you that most people will not get bad news when they do a mammogram. For every 100 women who do a screening mammogram, 90, ufa nipa oha, emu 90, yabeka cho moya mammogram ni yabeka cho say normal. See you next year. Emu 10 pe, and yabeka cho say, oh, ebia ye hu bibi, come back for additional test. Of the 10, no, emu 6. After they've completed the additional test, we'll be told that everything is normal. We'll see you next year. Afena ka 4%. Of the 4 people, 2 of them will be told, so we're not too sure. It might be something worrisome, it might not be. We don't even want to do a biopsy now. Instead of coming back in a year, come back in 6 months for another follow-up mammogram. If the mass is the same in size, then it's not cancer because cancer grows. If the mass has gotten bigger, then it's suspicious, and then we'll do a biopsy. So it's only 2% of women who actually get a recommendation, 2 out of 100 women who do a mammogram, who are told you definitely need a biopsy. And when we tell you you need a biopsy, it means that it looks suspicious. That's why we're saying you need a biopsy. So don't be afraid. Most of you will go home without being told you have any abnormality. Okay. So far we've been talking about screening mammograms. Once you have an abnormality, when you come back and we order additional tests, it's now called a diagnostic mammogram. It's at a higher level. Now we know you have a mass in there. We need to see it better. So we have a special mammogram called a diagnostic mammogram, and that's when they do that. So if you hear of a diagnostic mammogram, that's what it is. Or if a woman already can palpate a mass, or for instance has some nipple discharge, and I'll talk about that, and comes in for a mammogram, we're going to bypass the screening mammogram. We know there's a mass there. We're going to go straight and do the diagnostic mammogram. So what are some of the symptoms of breast cancer? Menufui, I was some call my doctor Eshemami because maybe so some of the early signs, nipple changes. Okay, but at all times you should feel your breast, you should palpate your breast. Okay, and then you should be standing in front of the mirror and comparing the two. If you see any what we call asymmetry, one breast looking different from the other, that could be an early sign. And even something as subtle as the nipple, if the two nipples look different, particularly sometimes the nipple can dip inside, we call it dimpling, you should seek medical attention. If you have bloody discharge, even if you have clear discharge, because under no circumstance, apart from if you are breastfeeding, must you be having any discharge from your nipple. So any discharge from your nipple, seek medical attention. Obviously, if you feel a lump in your breast, you should seek medical attention. Sometimes you see a change in the color around your nipple. That calls for seeking medical attention. We have a condition, this is serious, but you might not recognize it, where your breast, actually the skin overlying your breast begins to look like an orange peel with multiple dimples in it. We call it put orange, seek medical attention. And then if you have breast pain, however, I want to caution you a little. When you have your menstrual cycle, your breast feels heavier, you have breast pain, then it goes away. That's different. This is constant breast pain unrelated to your periods or your menstrual cycles. You should seek medical attention. Okay. So that is about screening and about early detection. There are areas I haven't covered. I know that. So if you have any questions at the end of the session, you can feel free to ask those questions. So now we're going to talk about how breast cancer impacts African American women and a condition that we call triple negative breast cancer. Afedie so no yebeka breast cancer. Any sanya affect yen ebibifo emma no. Sanya beya yebehu se e was say yehwe saa yare ye when it comes to African American women. Okay? So know your facts. So numbers here I'm at display here. I don't expect you to be able to cram these numbers. And numbers, it is just there to, in a way, to wake you up. Okay. But there are certain things I want you to know. So the first thing I want you to know is that actually the incidence of breast cancer in Black women, African American women, ourselves included, is actually lower when you compare us to white women. Okay, so the incidence is lower. One would think that if the incidence is lower, then our cancer, our breast cancer mortality or death rate should be lower. And that's the irony. It is not. It is higher. It is a whole 36% higher. An African American woman is less likely to be diagnosed with breast cancer, but more likely to die from breast cancer. When we look at survival, so we're talking death over there, survival how many people are surviving, our survival is lower as well when you compare it to the white woman. Our 5-year survival is 84%, and whites it's 93% overall when you include all the stages. The average survival, 5-year survival is 93% in whites and 84% in African American women. Then there's something called triple negative breast cancer. It's the most aggressive breast cancer. It is higher. It is 2 times higher in African American women compared to whites. And it is even higher when you go to Ghana, and I'll talk briefly about that as well. African American woman is more likely to present at diagnosis with a late stage. So we are more likely to present with stage 3. When the white woman is showing up for the first time with stage 0 and stage 1, we are showing up with stage 3. And the reasons are multiple, or I'll say mainly 2 reasons why we have all these statistics. One of them is what we call social determinants of health. Example, socioeconomic status, where you live, lack of access to care, insurance, baby, I would tell no hospitals, no papa be, draw where you see, be where you say. All of that is what is impacting the African American woman. The second reason why we have these statistics that are not as good as the Caucasian or white woman, and yet the biology of the breast cancer. The biology of breast cancer in African women is more aggressive. That's why we tend to have triple negative breast cancer. So we have 2 strikes against us. When we get breast cancer, it is aggressive. And because of socioeconomic issues, we also do not get the care that we should be getting. Okay. And well, I've tried to depict it here in so many different ways. If you have 10 women dying from breast cancer, 14 women will die. So 4 extra women, African Americans, die from breast cancer. But there's hope. Like I said, even though our mortality rate is higher, it is declining. Survival is improving. Okay, and this gap here, just 3 years ago, used to be a difference of 44% between Blacks and whites. It's now 36%. So it is improving, but knowledge is power. Knowing that we have all these odds stacked against us, that is why it's imperative as an African American woman to get your mammogram so that you also will present at stage 0 or stage 1 and have the same survival rate as the white woman. Okay. Yeah, and this I've explained, I've mentioned already that early detection and treatment advancement is what is responsible for the reduction in breast cancer death and improvement in breast cancer survival. Okay, so how much time do I have now?
I think 5 minutes.
I have 5 minutes?
Yeah.
Okay. Okay, I'm going to skip a number of slides and go on to risk factors. Okay. Let me show you this. So this is a study from Ghana where they looked at what we call triple negative breast cancer, which is the most aggressive form of breast cancer. They compared it with African Americans here and whites here. And in that particular study, 83% of breast cancers, the specimens that they collected, were triple negative breast cancer. African Americans from the US, about 42%, and whites, 15%. And so it is believed that the reason why in America they have more triple negative breast cancer than whites is that, yes, African Americans originated from sub-Saharan Africa. In sub-Saharan Africa, they have the highest rate, unfortunately, Ghana being one, of triple negative breast cancer. So that's the origination. It is believed that the proportion is less in the US, because you would expect that if it's 83% in Ghana, then it will be 83% in the US. It's believed that some environmental factors also come into play to change the nature of the cancer. But the bottom line is that sub-Saharan Africa has the highest rate, Ghana being one, of triple negative breast cancer, which is very difficult to treat. Okay, so I'm skipping treatment altogether, and I'm going to breast cancer risk reduction and prevention. So what is a risk factor? It's anything that increases your chance of getting a disease. Having a risk factor, though, does not mean you're going to have the disease. So I don't want anybody to get anxious that I have this risk factor and I have breast cancer. What are some of the risk factors? There's what we call modifiable and what is non-modifiable. Non-modifiable, being born female, getting older, you can inherit certain genes. We call them BRCA genes. If you have those genes, there are things you can do, but you cannot take away the fact that you have the genes. Having a family history of breast cancer in your breast cancer and know your risk factor. I mentioned dense breast tissue. Okay, if you've had multiple breast biopsies, and you say it puts you at risk. And a number of hormonal things. If you are exposed to estrogen, bottom line, for a longer period of time in your lifetime, you have a higher risk of getting breast cancer. And if you had your menses early, that will place you at increased risk. If you never had a child, it means that you're carrying estrogen along regularly, having one cycle after the other. That puts you at risk. If you got pregnant, if you had a child but never breastfed, because during the time you breastfeed, it suppresses estrogen. So if you don't breastfeed, it puts you at risk of getting breast cancer. If you have your menopause late, it means that all the while you are having one cycle after the other, you were being exposed to estrogen. It places you at risk. Modifiable. Drinking alcohol. Alcohol puts you at risk. Abstention is the answer. Being overweight, if you are obese or overweight, which most of us are, myself included, it puts us at risk for breast cancer. We need to exercise and lose all of that weight. Merely not being physically active. Forget about weight gain. You're just there, you're not physically active. It puts you at risk. Not having children, I didn't mention that. Not breastfeeding, I didn't mention that. Birth control pills do put you at risk. And a menopause, menopausal hormone therapy. A lot of times when women have hot flashes from menopause and a number of things, we go to our physicians and we ask for pills to help us. It all places you at risk of having breast cancer. You can go to your primary care physician these days. There are risk calculators that are available, and they can calculate your risk for you. And I put one example here. This is an online calculator tool. Don't try and do it yourself, although you can. That's why it's available to the public. The reason why I tell you don't try and do it is that you might not like the results. You'll be very anxious waiting for your PCP appointment, and it will take forever. So don't put yourself through that. Go to his office and have him do the calculation for you. As an African American woman, you might have a slightly higher risk. So I encourage everybody to go and do it. It has been determined that if your risk is greater than 1.7, then certain recommendations need to come into place. Okay, so and the questions are very simple. All the factors that I asked you about, they will input it into it. And so I put in a real patient, and that patient's risk came at 1.4%, and said that the patient's lifetime risk wasn't severe enough and didn't warrant any additional recommendations. Okay. BRCA mutation, genetic form or hereditary form of breast cancer. I'll explain it briefly. You inherit that either from your mother or from your father. In this picture here, the father is the affected one. When they have, so now they have 4 children. The father gave one gene, which was the affected gene. Everybody carries 2 genes, right? X and Y. Remember, and then the woman is X and X. So the BRCA gene can be carried on either the X or the Y. But once it shows up on one of them, it becomes the dominant presentation. It means that you have the gene. So the father here gave it to his son. Okay, but then he gave the other gene, the X, which didn't carry the gene, to his daughter. The woman here doesn't have it, so she didn't give anything to anyone, but the father gave it to 2 children. So that's how you inherit the gene from a parent, depending on which parent has it. If the parent during the process of conceiving transfers that gene to one child, that child carries the gene. If you carry the gene, what does it mean? If you carry the gene, it means that you have a 50 to 85% risk of getting breast cancer. That's what the BRCA gene means. You also have a 40% to 60% risk of having ovarian cancer. So if anybody has multiple family members who got breast cancer at a younger age, and because that's how it presents, one person needs to get tested. And if that person tests positive for that gene, it means everybody else needs to get tested. If you test positive because of all these possibilities, these high risk of having breast cancer, of ovarian cancer, you have to make a decision whether you're going to prophylactically remove your breast, even though at that time you're just carrying the gene, you don't have breast cancer, or you're going to remove your ovaries as well. These are some of the implications of carrying the BRCA gene. One thing I want to tell you though is only 10 out of 100 women do have this form of breast cancer. So it doesn't mean that once you get breast cancer, oh, no, you need to do genetic tests and I'm carrying the gene. It's only 10 out of 100, but it's something that we need to bear in mind as well. And I've mentioned these already. If you carry the gene, or if your risk calculator shows that your risk of breast cancer is high, there's genetic counseling that can be given to you. There's medication. There are pills that we can give you to lower your breast cancer risk. You can do surgery, remove your breast, remove your ovaries, especially if you finish having your children. These are all things that you should consider. And then if you decide, it's not severe enough that you should be having any surgery or anything removed, well, your mammograms need to be done about every 6 months. And it's a mammogram alternating then with an MRI. And a lot of hospitals in the United States, the big hospitals, now have special clinics where such patients are seen. Okay. The last thing I want to mention is that up to 30% of all breast cancers can be prevented. You see, when we talk about early detection, it means you have breast cancer, we are catching it early. How can we even prevent it from happening? Up to 30% of breast cancers may be preventable with changes in lifestyle. And the American Cancer Society has determined that maintaining a normal body weight, avoiding physical activity, avoiding or limiting alcohol can reduce your risk of getting breast cancer. And anytime I read this, I am reminded of the divine wisdom of Ellen G. White, because these were the principles of her health message, which at some point people did not believe, but now have been embraced. And also remember to get your mammograms. Thank you. So I'm going to stop sharing, and I'll be very happy to take your questions. And I'm very sorry, because of the lack of time, I had to just stick to English because translating back and forth was taking up a lot of time. So I'm sorry. But questions, mo betimi ebisa no twi, ubisa no twi a meyi anu twi ama. Right. That's it.
Thank you so much, Dr. Also. Me also Sister Debbie Epijanisa. But before then, I realized that you were comparing the black Americans and the whites, the rate at which the black Americans get the breast cancer is very high. Is there anything that we are doing and the whites are doing that is different? Are we, the blacks, supposed to also be doing it? Like our food, water, or anything? Because I see that there's a lot of, what's the name? Black people, especially in the community, are getting this breast cancer, and it's becoming like a pandemic, So what are we doing differently that is causing all these things?
Okay, so I want to answer that. I want to clarify something. So if you remember, I first said that African Americans or Black Americans actually get breast cancer much less than Caucasians. The reason why we tend to have the impression that African Americans get breast cancer more often is the bad news that overshadows the good news. The bad news is that African Americans, when they get breast cancer, are more likely to die. And so it creates the narrative that we get breast cancer more often. We don't. The incidence of breast cancer in African Americans is actually lower. Okay, but our breast cancer is more aggressive. We tend to be diagnosed with triple negative. We tend to show up at the doctor's office with more advanced breast cancer. If you remember, the more advanced your breast cancer is, your survival goes down. If you remember those pictures that I showed, where if you're stage 3, your survival is 87%. If you're stage 4, your survival is 32%. If you're stage 1, your survival is 99%. So the white woman is showing with stage 0 and stage 1. And then we are showing up with stage 3 and 4. And so we are dying more often, but the incidence is actually lower. The reason why the death rate for African American women is worse than Caucasians is for 2 main reasons. The first one is inherently, this is biology, we have more aggressive breast cancer, period, which is resistant to treatment. That is a different matter. The second matter is, even if we have more aggressive breast cancer or not, we tend to be underdiagnosed. We tend to be undertreated. We tend not to have access to health care. We don't have insurance. What we call social determinants of health, disparities in breast cancer. This is what is killing the African American woman. Okay, so social determinants of health are factors that one encounters in areas where they live, they work, and they play. So if you live in a poor neighborhood, when you are sick, you're likely going to go to that hospital in that neighborhood. That hospital cannot offer you the latest and best treatment. So right away you are undertreated, or they don't even have the ability to diagnose you properly. And that's what we see. So these are some of the issues why the African American woman doesn't do as well. And the evidence of that is when African American women participate in clinical trials, and that's another issue. When they participate in clinical trials or move joining clinical trials, in clinical trials, everything is provided equally. Then you see that the death rate is equal, survival is equal. So that tells you, say, it's the lack of resources that unfortunately we have that leads to those statistics.
Thank you so much. Sister Debbie, your hand is up. You want to ask a question?
Oh, yes. Yeah. Thank you. Thank you, Dr. Cynthia, for very insightful information. So I have say maybe a couple of questions quickly. The first one is you mentioned in the risk factors about when you start your period. So what age are you looking at? Is it like from below 10 or between 10 and 12 years when you first have your menstruation, or there's a set age that it's looked at? And I guess I'm asking because I had my period really, I was in grade 6. I think I was 10 or 11-ish. It came and then it took another year or year and a half before the second one came. But the reason why I'm asking is that recently was last year I have. So over here you have the mammogram. And my 2 previous mammograms, they mentioned I have dense breasts. And I thought it was for young people, but I mean, I turned 50 this year, so I'm wondering why I have dense breasts. But I'm petite, so maybe that's why. So then my doctor requested that I have the ABUS, which is the augmented breast ultrasound, which the mammogram did not show anything. But then last year when I did my ABUS scan, they actually found something in my left breast, and then I had to do the biopsy, which came back benign. But then I had to do, like, I'm still on watch. I did a 6 months and I'm due for another 6 months. But I just wanted to ask, so in this situation, does it mean my risk factors are more? I think my doctor told me I'm okay, but and I'm not really worrying about it because I'm doing routine checks. But I just wanted to ask does that kind of like increase my risk of something happening again? Or for now they said it's stable, it's under 1 centimeter, so nothing, like it's not being removed or anything. And I guess when I have my next scan next month, I would ask whether it would still be the same, or yeah. So that's my questions.
Okay.
Thank you.
Thank you. So that is very interesting, and I'm very happy that you've narrated your story, because sometimes when we give these presentations, if you don't have a real human being to tell their story, sometimes we don't pay attention. This is real. A lot of the risk, or if some of the risk factors that I talked about, and some of the things that I talked about are right in your story right there. I'm going to start at the end. The good thing is that you are having what we call short-term mammograms. You are under scrutiny. Nothing is going to escape anybody. So you should feel comfortable and you should feel happy that you have an extra set of eyes on you, and they will see you through to the conclusion of whether eventually you should have a biopsy or not. So I don't want you to worry about anything. Do you have some of the risk factors that I mentioned? Yes. But it doesn't mean your risk is going to be high. There wasn't enough time, so I wasn't able to walk you through the risk calculator, but you would have seen that it is about 12, the one model that I showed, and there are different models. The model that I showed you is called the Gale model. There are over 12 questions in there. One of them is, yes, did you have your menses early? And have you had a biopsy before? And how many times you've had a previous biopsy that was benign? It is not one risk factor that makes your risk high. It's a combination of factors. So I don't know whether your risk and your age is included as well. So I don't know whether your risk will come up to the 1.7% or it will be less, unless that information is put into the calculator. Regardless, let's assume your risk is high. What's going to be done? One of the things that's recommended is what's being done for you, which is the close surveillance. And that's why I'm saying that is the good news. So whether your risk is high or not, you're under surveillance and the right thing is being done. I hope I've allayed your anxiety and answered your question.
Yes, I think I've not, since I had the biopsy last, I think it was just before Christmas, and they said it was okay. I'm not really becoming worried because they said I would be under routine screening. But I know sometimes these things, it's like it's okay, and next thing you know, all hell is breaking loose. So just want to make sure that you like everything, but everything is in God's hands also. So yeah, for now, I'm not too worried about it. Yeah.
And about the menses, it's not a specific, there's no specific age.
Okay.
Yes, there's no specific age. Yeah.
Okay.
Yeah.
Thank you.
Mm-hmm. The calculator will ask you, it gives a range. And let me see what the range is. It gives 3 options. So did you get your menses between 7 to 11, I believe, then between 12 to another age, and so forth. And then it awards points based on that.
Thank you so much. I see
You're welcome.
Hands is up. You have the floor to ask your question, please. Mr. Frank Asumeni.
Yeah, Cynthia, thank you very much. I'm so proud, a Ghanaian in America. That is so encouraging. I have 2 guests, and that's so encouraging. I have 3 questions. Do you want me to ask them all, or want me to ask them one by one?
I think one by one would be helpful.
Okay. My first question is, me wa down for Ghana. What's in new for you? It means for 3 days. Na ko Accra, na Sabibio, sa hospital, government hospital. Obviously, there's nothing wrong with the breast. Or if you be 80 years, do you have any idea what could be happening? I don't expect you to diagnose it because you don't have the laboratory evidence or anything. But what could be the problem?
Typically, though, even though breast cancer to me causes pain, it is not one of the first things you see, and it is not very common. And now cancer grows if you don't treat it. And to all this while now, on and off. The cancer and by this time Juabi Abeshahono.
Okay.
If it's been going on for a while, I'm not thinking say it is cancer.
Then what call government hospital on the share so-called FDM or Ghana? Almost there's nothing in it. So why is she still experiencing pains?
Sometimes you can have referred pain. That's what I'm thinking it is. But I mean, like you said, I don't want to diagnose it because I don't know the history.
Yeah.
Sometimes you can think that you have pain in your breast, but the pain is coming at her age. I'm going to think that she has arthritis.
Arthritis?
I'm going to think that she has arthritis, joint pains.
Does arthritis affect breasts?
Referred, that's why I said it's referred. It could be referred.
Okay.
Yeah, the pain could be originating somewhere, and then radiating to the breast such that it makes her think that it is the breast.
She has arthritis.
Yeah, that's what I'm thinking.
So
it is.
maybe you are right.
Yeah, I've seen it many times. So I think probably that's what's going on.
Okay, that makes sense. Okay, my second question. I'm a girl. My mother had breast cancer and died of it. Is it automatic that I'm going to have breast cancer?
It is not automatic. However, this is where family history becomes very important. If the mother had breast cancer when she was 50 years and younger, then this daughter needs to go and check for that BRCA gene that I talked about, and she would qualify for the test. The test is very expensive, but if your history points in that direction, at least in the US, they'll do it for you.
No, but it's in Ghana.
Oh, this is in Ghana.
Welcome to my world.
Oh, are you calling from Ghana?
No, I'm in Canada.
Yeah, in Canada, but your relatives are in Ghana.
Exactly.
I believe that, I know that in Ghana they do the test as well.
Okay.
But it costs money is what it is.
Fine, but it's good I know.
Yeah, it is the obetimi acquire test now. And then acquire test no. Now, so testing na so you're positive. But then the other question I'm going to ask you
Hold on. Going to do test for cancer?
No, test to see say ni maame nya breast cancer or no obetimi enye bia.
How would they do that? Because you know Ghana, when obi and record information about even what happened, right? I mean, this is kind of talking about.
You don't need.
Did my mother have the safety?
You don't need that information.
Oh, okay.
Information here na maybe says any maame no or who you know you're 50 years or younger now.
More than 50 years.
She was more than 50 years.
Yes.
Oh, if she was more than 50 years, the commonest reason why any woman gets breast cancer is because you are female and you're getting older. The recommendation is so being breast cancer, not so you're 50 years and older, dear. You should not think say a hereditary. Or your partner in breast cancer. Then in that case, it doesn't necessarily mean say however, say mother no was young, dear, less than 50 years. It looks suspicious. The test is a very simple test. A blood test. You so the saliva in your mouth. That's all you need. It's a swab.
If it is answer, said okay, said mommy younger. Of course, it's a then on can show say what test is that she want.
Oh, she doesn't need to say remember anything. And once Rebecca said, "Ne maame enya breast cancer at the age of say 45," if that was the case. Into or person more test so no so no obetimi breast cancer. O catch yes or will be obetimi we are talking about the future. So right now she does not have breast cancer. O catch doctor bia onimade kura o can.
That's it. Thank you very much.
Me did it say smaller hospitals won't have it, but polebuni confanoche de nimisa omuyebi.
Okay, thank you. My last question. Do men get breast cancer?
Do men? Oh, that's an excellent question. The answer is yes. The answer is yes, but the incident.
You say no.
Oh no, the answer is yes. Omunya breast cancer, but it happens less often. Say, me started and me can say in 2024 in US, over 300,000 women in the Benya breast cancer. For men, about 2,500 men. Into
Wow.
the incidence is much lower. Yes.
Oh, but it's too high
Breast
it's
cancer.
too high for me.
If I just say,
It's too high for me. I didn't expect men to get breast cancer.
they
Well,
do.
and they go ahead and tell us, how do we know if you do have one or expect one?
Yeah. The incidence is so low, say, men do not need to undergo mammograms.
Thank God.
Yes. And now, two, no, unse, remember, you need, omuni enufuo. Inti juabi befua ho a sisi a ombehu.
Mhm.
That is the only way you know, say, when you have breast cancer. Nti esa na call kohun or doctor, all the tests na mekayen. At that point in the mammogram, no be a ultrasound, a biopsy. Now, determine treatment at the boa, no more. And a bema bia, obenya breast cancer bia, no. Sa test ya may describe it sure we genetic test, no. Bema bia, onya breast cancer bia, in America, dear, ombeya osa genetic test maybe.
Thank you, Cynthia.
Say, the entire wunya breast cancer no ne say wo maame ana wo papa e passe saa gene ni ma because anya saa dia isen ka bema enya breast cancer.
Thank you. I appreciate it. That's good information.
So much, Dr. Cynthia, for allowing yourself to say, Nyame, also, October is breast cancer month. You see, we are so privileged to have you here. In some of our country, in say in a boy, decision. Yeah, doctor, yeah, we are of age, but yeah, we are breast cancer screening them. We'll go in and do the section. Every boy in Amaya Yamisha for allowing yourself. Yami, every friend, Edmonton facility, this Mr. Samuels. Now, a bonfire mama, Dr. Cynthia. Now, was Serena Mishramano. Let me speak English. Yeah, we are going to ask the First Lady of Edmonton Church, Miss Samuels, to pray for Dr. Cynthia for allowing yourself to and also a ministry for us. And also pray for everybody that came on the line. God should bless them, all our visitors that will be trying to come on the line to help this program to be successful. So, First Lady of Edmonton, Mrs. Samuel, she can say a word of prayer to close this program. Thank you so much, Cynthia, also.
Medase. Good evening, everyone. Good evening, Dr. Cynthia. Before I pray for you, thank you so much. It was a great bit of information, great encouragement to go get my mammogram. Okay, let us pray. Loving Heavenly Father, I thank you so much, dear God, because wisdom is yours, honor is yours, knowledge is yours. Health is from you, blessings are from you, and you have gifted your daughter with so much of it, so much experience to share, to bless others. And this evening we have received, we have heard, and we are encouraged to take care of ourselves and our families. And I thank you, dear God. I ask a blessing upon her in her ministry, as she is a physician, seeing so many women, sharing with so many. I pray that you grant her good health, peace of mind, continued encouragement and hope to share with others, with everyone she meets. Lord, I pray for her own family, her personal needs, everything, dear God, that she touches, that she would continue to dedicate it to you, and that you would continue to give her a blessing to continue to faithfully work for you. Lord, if there's any lack, anything that she just cannot handle, I pray, Father, that you would grant her a double portion of what she is in need of. And Lord, for each of us here, and for those who should be here who are not, for the rest of the series of these meetings, Lord, that more women will come, more men will come and hear what we need to benefit our lives. Surround us all, Lord, until we meet again. I thank you so much. In Jesus' name, amen.
Amen. Thank you so much for that prayer.
Amen.
And thank you for having me. I truly enjoyed it. May God bless you all.
Thank you, too. Bye-bye.
Bye.